Okay, welcome to Hormonify's podcast with Dr. Eckert. That's me. Today we have a special guest, one of the long-term nurse practitioners at Hormonify, and this is Kristi Bernardo.
Hello.
Now, today we're going to talk about a topic that's very near and dear to us because we deal with this issue every day, probably 20 times a day, and that is human sexuality and hormone replacement therapy, how they intertwine. But before we do that, I'd like to go ahead and mention something that happened 2 days ago. You all may know that, and the FDA has finally come out with a formal announcement that indeed hormone replacement therapy did not cause increased breast cancer risk. Now, that's what I've been saying for 35 years. There is no research to support that. However, the FDA was reluctant, under the guidance of pharmaceutical company representatives, to actually come out and admit it. So therefore, now that gives us more credibility than those that said, well, you really shouldn't be taking hormones because it can cause breast cancer. Certain hormones can, not our hormones and not balanced therapy, and definitely not progesterone-based therapy, and definitely not bioidentical hormones. This brings up the issue of what is the significance of the FDA announcement. First of all, it's a definite political shift. However, to me, because everybody's been calling me and texting me, wow, now you're free, you can go do what you want to do. But to be honest, I really didn't care what the FDA had to say. But what I do care, this is the road to allowing the equalization of bioidentical therapy with pharmaceutical-based synthetic therapy, which means that ultimately the goal of Hormonify, with your help, will be to make insurance companies cover the cost of bioidentical hormones made by pharmacies that are not necessarily based on synthetics. So that to me is a big plan, which I think will happen because now we have close to 4 million American people on bioidentical hormone replacement therapy. That's very significant, and it's growing rapidly every year. So what we need to look at as that small step toward realization that the misinformation that was propagated by pharmaceutical companies, their representatives, and most medical schools, residencies, and doctors stating false information has now been revealed. So my advice to you, when you do come to us or not, is that once you get on the therapy, you can discuss it with your family doctor, with your gynecologist, because we have people all over the country in every state but Alaska. And we found that they know nothing about what they speak. It happens every day. We put people on the program based on laboratory testing, symptomatology review, and their doctor says, don't take it because it causes breast cancer. Those doctors probably won't even know what the FDA said. So my advice to you when we start out about anything related to our program is that not only is it perfectly safe, but it is changing people's lives drastically. One of the ways it changes it is the sexual interaction with their partners. So today we're going to discuss more in depth about our experience with that. So why don't you begin to give your view on how patients present to you the various sexual issues?
Well, I really would have liked to have seen the FDA recognize testosterone because they just kind of touched on progesterone, estrogen, but left out a big point of the benefits of testosterone for women. Because that's part of our therapy. It always has been. Huge difference in bone density for women, in addition to all the other benefits, weight, metabolism, bone density, lean muscle tissue, but definitely sexual desire, which is what we're focusing on. And of course, that affects sensitivity down there as well.
Down where? You mean
In
down
the
on your
genital
knees?
area.
Oh,
On the genital
okay.
area.
All right. Kristi's
down below.
Kristi's from Jacksonville, Florida, so she's a little
So I
conservative
get made
about
fun of
mentioning
all the
that
time.
all the time. Anyway, so down there is something that needs to be more explicit. So in the vagina, what you're saying, it actually changes the ability of a woman to have intercourse. Has that been your experience?
It's sensation.
Okay.
But we addressed, multiple issues. Of course, with estrogen, that helps the elasticity, that addresses vaginal atrophy. Of course, and the moisture, how comfortable intercourse is.
So when women have vaginal atrophy or dryness of the vagina, how does that affect their sexuality, especially with their sexual
Well,
partner?
if it's not comfortable, you're not going to be able to relax and enjoy anything. It's not going to
It's
make
going to
you
hurt.
want to participate if
Right.
something is painful.
Correct.
And sometimes the partners are understanding and sometimes they're not, and it causes a
Well,
lot of tension.
unless you're a masochist. If you're a masochist, then it's fine, right?
Yeah,
Otherwise,
assuming most people are not.
are not. So those out there that are having trouble sexually with their partner, and they pay kind of are they embarrassed by it? I mean, do you find it people incapable of openly saying I can't have sex, or do you have to ask? Do you
I think
specifically?
they're getting better. There's definitely people who are more conservative or feel guilt or shame or maybe have some little religious type background where that's never been discussed in their household. So it's kind of like
Even
this.
with their sexual partner.
Yes,
So,
definitely.
so
But it's
from
getting better. I feel like it's getting better as I talk to them and say, this is important. You know, we're going to cover this, and it's a big part of your marriage and your self-esteem and how you feel, and it's a stress reducer, and it actually has so many health benefits. And I think, you know, over time, you know, talking to the same patients for years, I think many of them start to feel more comfortable.
Well, what I've noticed, I don't know how whether you agree or not, but I noticed that women who begin the hormone therapy, even if we don't discuss their sexuality, will volunteer to say, you know what, my husband's happy. That's what I hear all the time. Not that they're happy, my husband's happy.
But then I ask, are you happy?
Right.
Let's talk about you.
There you go. And so they even even when they're better, they have a hard time talking about their own sexuality to relative strangers like us. But you know, as you know, I have a master's in sexual therapy, and I did that because I wanted to know how to discuss with patients the issues of sexuality. It's a way of discussing it, and I'd say 99% of the time, people accept that and they understand that this is part of what it is that happens when you improve your vaginal lubrication and elasticity, and also desire. So talk a little bit about, you mentioned testosterone and the effects of that. I believe that the system now does not want to recognize the value of testosterone in women. I believe that is true. I agree with you. And there are articles put out by major menopause societies that still say that testosterone should not be given to women, which is incredible fact that women do have testosterone levels. They have testosterone receptors. They have receptors in their brain. So therefore, to me, that is, again, anti-scientific. So I question that, obviously, and we do administer testosterone for various reasons, but also to enhance the woman's ability to have an orgasm. Have you found that to be beneficial?
Oh,
Or true?
definitely, definitely.
I'm not talking personally, I'm talking
I think
professionally.
there's just this little, we're still behind the times and thinking as women, as they get older, that's like their sexual life isn't important, or that's not important, that women don't want to have sex. And of course we do and want to enjoy it. And of course that keep that intimacy, you know, with our partners. And I think that's just the assumption that as women get older, they're not interested in sex and it's not important and that doesn't need to be addressed.
Or
which
it's
is
or
sad.
it's
And
or
no
it's
one addresses it.
Right.
No one even asks about it.
right. Family doctors don't do it. I found that to be a commonality, which is really unfortunate. And gynecologists definitely, you know, they're the quickie in and out now. I mean, they don't even. I have patients who tell me that my gynecologist spends 3 minutes with me, and our visits are about 30, 40 minutes. So in other words, you can't get into a sexual history because sometimes there's other issues with the sexual history of the woman that does come into play. I'm not talking about society issues. I'm not talking about toxic feminism or toxic masculinity, which is another topic we can discuss. But I think we see patients who absolutely no one has ever asked them about their sexual history.
I just had someone in the GYN office last week, 64 years old, vaginal atrophy, dryness, burning, pain, unable to have intercourse. She's gone and had pap smear every 1 to 2 years for years. No one even offered her estradiol cream, let alone
Which is-
systemic hormone replacement, but no one even gave her,
Right.
addressed that, gave her
So to me-
any
see-
estrogen
see-
cream.
See, to me, I've been doing this now almost 40 years. Next year it's going to be 40 years. And I have found a further decay of the relationship between the doctor and the female patient primarily.
It's
That
sad.
is that they don't even want to address anything because they're fear that some claim is going to be made or they're acting inappropriate, which is really unfortunate because who are the women going to go to? They don't want to discuss it with their husbands or sexual partner, usually. Sometimes they do, and it's good that they do, but they have no one to go to, so they suffer in silence, which to me is totally medieval in the sense of modern medicine. So especially
That's a good
gynecologists,
word for it, medieval. I was
especially
going to say neglectful, but I mean,
who is less listening to women's sexuality, men or women? Female
I think
gynecologists?
female, which is
Females.
shocking to
They
me.
shut it down. It's amazing to me, 3 to 1.
And I'll say, how old are they? Because I ran into that recently too, and it was
Uh-huh.
someone in their 30s. And so, well, give her some time. When she realizes how
They,
important her hormones are, they start to disappear. She'll be more interested in helping you.
it's about confidence in what you're doing in your own life and confidence in your own sexuality, but also confidence in actually being a doctor, not just being I call it a pap smear doctor. I said, any moron can be a pap smear doctor. And I'd say 90% of gynecologists, that's all they want to do. Do the pap smear, get in and out, refer something if you have to. I'm not talking about obstetrics, gynecology. They don't want to get involved because it takes time and effort and education.
They never ask about sexual health.
Not at all. And therefore, you, as a patient who's listening, just ask your gynecologist. And if he or she doesn't want to answer, you say, excuse me, I want an answer for this.
But they don't ask because they don't know what to do with the answer that they get.
At least to make the first step of at least retraining the doctors to be doctors. I hate to say it, but at my age, I think that what I've learned over the years is that most doctors just don't care. They could, and if you have a doctor like that, change. Find someone who cares. One of the indications I find is that they care about your sex life or the medical aspects of your sex life. You don't have to get into the details. You just have to say, how often do you having intercourse with your partner? I haven't had intercourse in 6 months. Why not? Because it hurts. That's 20 seconds. Well, then I think we need to send you to Dr. Eckert and get some hormones so we can go ahead and fix you up. Same thing with osteoporosis. See, osteoporosis is related to older women, but almost all of those women who develop osteoporosis had hormone deficiencies for 20, 30 years. And nobody asked them. And in that period of time, they had sexual issues. So it leads the conversation toward preventive health, which is what hormones are really about. It's preventing. We have, 26 symptoms. And I think I was on film one day when I said I had a patient who had 14 symptoms, and she had one symptom, and she kept on complaining about her hair. But 13 are gone. I said, 13 are gone? Yes. I'm so appreciative. But women being women, they complained about the one symptom she still had. And this is only...
Which takes the longest to resolve. So
that hair is I explained it
with
to her, but she had 14 symptoms total. So what is it that is missing in medicine, you think? What is the problem? Why can't people talk about their sex, especially women? And we'll talk about men in a minute. What's missing? What's the fundamental flaw that patients are accepting inferior care? What is it, do you think, in your experience? Not only as a woman, but also as a nurse practitioner.
Going back to women not feeling comfortable talking about it.
That's
so
true.
Are they feel intimidated when they go in, so they don't want to say anything? Whatever the doctor tells them, they just say, okay. And they walk out and they still feel just as bad and don't know what else to do.
Now, aside, we see a lot of men, and I have no problem. Men open up right away. I just ask them, boom, there's no problem talking about it. It takes like 3 seconds. They're almost glad to talk about it, and the fact is that a lot of times they have erectile dysfunction, a lot of times they have other sexual issues, but they're happy to talk about.
They don't have anyone else to talk to. Women talk to their friends, like we'll just share anything and talk with each other, but men kind of stay in their lane.
I think a study did that men think of sexual issues 15 times a day. It comes up. Whether they see someone or they're thinking about their partner, whatever it is. Women, it's 17 times. There's probably no difference. We don't talk about that. So sexuality is incorporated into our subconscious, and there is recurrent thoughts of sexual function throughout the day and night. So we don't acknowledge that because, again, in our culture, in our society, what I've observed, especially doing this for 40 years, is that we almost have a subversive view of female sexuality. And it's unfortunately exhibited in bad places, like nightclubs, which is not very healthy. I'm talking about relationships between a man and a woman where sexuality is involved. And opening up the conversation, especially to men. That's what women think. Oh, he's not interested. Well, maybe he's a little embarrassed, a little ashamed, or maybe he feels like it's uncomfortable, but I still think he's interested. In fact, I know he's interested because people tell me, all right, all the time. How interested my husband is now that I'm talking about issues in our sex life, he is 100% on board.
You
Especially,
have to open up that door. That's what the testosterone helps with. It kind of brings
yes,
that out. It's like, okay, now it's moist, now it's comfortable, so I don't have to worry about pain anymore. And then the testosterone helps stir up those thoughts. And then you start talking about it, and it opens up that door
well,
to let's go back and forth and kind of
well,
reignite everything again.
that brings up what I say sometimes to patients. If you don't use it, you lose it. And I think it's true.
That's true with the receptors in that in the
That's correct.
genital area down below. All the patients I have know.
You see, if you say
down below,
down
and
below,
they know what I mean.
you may think you're talking about
But-
Australia. That's what I mean. We have to make sure we're not.
Only in
Okay.
Australia.
Only in Australia.
But I mean, if the receptors aren't as sensitive, you haven't been
Correct.
using it. And then another thing, like, women don't want to talk about masturbation too. So when I try to women who are single, we talk about that too.
Absolutely, the time period between orgasm is longer. It is definitely more difficult to get back onto the regimen. So that is the role. And Mess and Johnson did a lot of good work about 60 years ago on that. And that you have to continue the neurological aspects, not just the hormonal aspects and the vascular aspects and the mechanics of it. The neurological aspects is that there's a lot of evidence to support the fact that a woman can shut down her sex life and not reactivate it, even with hormones. So we do encourage that there is more of a clinical approach to it, that activity would definitely benefit, especially a woman. But
Some
let's,
women don't touch themselves at all because I'll ask even about vaginal moisture. Has it improved? I don't know. Well, feel down there.
well,
and
what I
see.
say to them is should we ask the audience to call a friend? That's what I usually say. And they usually laugh, and then they, oh, well, I guess I do know, So you just go ahead and try to use, that's a great line. I think you should be able to use it. So
When they meet someone, then all of a sudden the thoughts are there,
Well-
and they're interested in meeting someone and getting back out there, and then they're like
Yep.
in a panic. Is everything okay down there?
That's right, and they have to check. So that brings to mind about meeting someone. So we have a lot of people, especially in their 50s and 60s, whether it be divorced and never married, widowed, who are not sexually active and yet want to be. So they deal with their body issue, they deal with weight, which we help them with, we deal with nutrition, we deal with all sorts of aspects of their life.
That's a big part of it for women. It's our self-image. If we
Correct.
feel comfortable with not just feeling safe and the relationship going well, but feeling like we don't have to worry about what we look like and relaxing and enjoying the moment.
Right, it's about whether the light should be on or off,
Definitely.
But I was going to a point where it's very fascinating to me that women told me, and I didn't know this when I started doing hormone therapy, that once they're on the hormone therapy, men notice them more.
No, I've heard patients say that.
Meaning
Definitely.
that they get more attention, even if they're not doing anything different, they're not dressing different, they're
It's
not
the
body.
energy. It's the testosterone and sexual energy and
The
pheromones.
pheromones,
that are going
exactly. Keyword pheromones, look it up. Pheromones get exuded. Men were an animalistic in the sense that we subconsciously sense the byproducts of testosterone mainly, but also progesterone, that a woman is in an ovulatory or reproductive state. No one really knows where in our brain it is. It's probably everywhere, but men pick up on that. I can't tell you how
like
many
all
patients,
animals.
probably 1,000 patients telling me that I didn't do anything differently. These guys come up to me and now I have a boyfriend, and before I didn't do anything different. It wasn't like someone who lost 30 pounds and it looks better. I have some of those as well, because that's where the GLP-1s come in. But in terms of just pheromones and utilizing the natural attraction that men have, some of it is pheromones. It's
Some are
hormonally
attracted
driven.
to certain pheromones. That's why you have attraction to some people and not to others or anything.
It's
He's
proven.
nice looking, but I really don't feel that much. Why
Right.
am I into this guy?
Well,
But-
that could be for other social reasons, but I have patients who tell me, by the way, I said, oh, are you sexually active now? Yes, I am. Oh, good. I met a boy. When did you meet him? 2 months after the hormones started. So in other words, there is something else to say in the sexual life of a woman especially, that putting yourself on the proper hormones, releasing the pheromones will actually attract men for you if that's what you're into.
That's the progesterone too. With the
Yes.
mood regulation, it's like,
Ah, there
okay,
you
I
go.
don't have as much anxiety, irritability. I feel a little calmer. So they handle
How
things a little better. So you're ready for that mentally, not just like the sexual aspect, but you're in a
it's true.
calmer state.
Yes. Sleeping better.
Mm-hmm.
Who would want to have sex if you don't sleep well,
Better
tossing and turning
energy.
all
If
night?
you don't have any energy,
But you know, who would want to have sex? I mean, they're tired
mm-hmm,
and they're fatigued. They don't sleep well. They have energy issues from adrenal gland insufficiency. They may
mm-hmm.
have other things going on that we pick up, thyroid problems. So why would they want to have sex if they're exhausted?
Mm-hmm.
I mean,
and no
as
one
opposed,
addresses adrenal
no one
function
addresses
ever,
adrenal gland.
ever,
And that's
ever.
very important that we address. I figured that out about 30 years ago. And of course, now with the COVID vaccinations and the effects on the adrenal gland, I saw a marked increase of adrenal insufficiency since the COVID vaccinations. That's a conversation that we can have another time. But how does energy level affect sexuality? Of course.
Yeah.
You know, and yet the doctors don't address it. I have low energy. Okay, they'll do 16 pages of lab tests. They don't take a history. They don't figure out what's going on. I'm not sleeping well. What happens? I can't fall asleep. I got hot flashes, night sweats. I'm irritable. I'm stressed out. I'm anxious, and everything is going bad in my life because I'm not having sex with my husband, and he's upset. Everything is falling apart. Nobody finds out. Fix the problem. Get to the source of the problem. You know what the doctors do? They give them a sleeping pill, and then they give them an antidepressant.
Antidepressant.
And then they give them an anti-anxiety pill. And then the patient's a zombie. They're not any
Or
better.
Adderall or
Whatever it is. But the point is that
Trazodone.
treating symptoms. Isn't that a common thought that what Hormonify does differently is that we actually treat the cause of the problem? That's why we have 26 symptoms. When I ask the questions, people say, is that related to hormones? I said, yes, it is.
That's why we pull psychotherapy into the picture too. Because
You want to talk about that?
sometimes if this isn't resolved, okay, what's going on? I mean, sometimes I can have patients where we work on the libido and the relationship's good, the body image is good, but there's sometimes they're either just fatigued or, you know, we're working, balancing hormones, and then they'll go on vacation. They'll tell me, oh, yeah, I'm almost out of my troches. I've been on a cruise for the past week. How was it? Oh, great. So see, it's just life. You got busy and you're tired and you got little kids or teenagers or whatever, and it's completely different than when they have no distractions and it's just them and their partner. I see that a lot too.
You know, we have tens of thousands of patients, thank God, but nobody's on antidepressants unless they insist absolutely we take them off, and not, they all say, I feel better. All of them. I have had one patient, one patient who went back on because her doctor said to go back on. Because you can withdraw slowly. We have a program which I developed. It takes 2 to 3 months to withdraw from these poisons. And we try our best to make sure everything else is fine first. The nutritionally is fine. Hormones are fine. They're sleeping better. Their lifestyle gets better. Their sexuality improves. Then we address getting them off the antidepressants.
Sometimes that's the culprit. Everything else is resolved, but
Good
libido.
point.
Okay, let's look at these SSRIs.
They depress.
That's a huge side effect, and it decreases sensation. So some women still have libido, but they're not able to reach an orgasm. It's a side effect of the pharmaceutical.
Absolutely. And yet, when they go to their family doctor or neurologist, psychiatrist, especially psychiatrist, all they want to do is put them on medication. So we believe that in the interim, in the middle zone, I call it what's left syndrome, which means once you take care of the hormones, everything's perfect, everything is great, everything is fine, except they do have issues related to either their sexuality or their mood. What's left is get a psychological history. Have they ever had sexual abuse? Unfortunately, you would never suspect. Yes. Nobody ever asked me. I had patients. And I go through what happened, and they have PTSD from that. So psychotherapy is recommended versus medication. So they're treating medication for people that have tremendous anxiety, especially sexual dysfunction, and nobody asked them, were you ever sexually abused? I mean,
sometimes they don't want to go for a pap smear or even a mammogram. And then we'll delve into that and find out if they were, had sexual abuse. And so they don't want anyone looking at them, touching them, and that's never been addressed.
So when you deal with sexuality, you notice it encompasses so much, and we're going on and on and on, But when you deal with the male, it's much simpler. Women are much more complex, and in my experience, almost always men do better if they feel better about themselves. And if they think they have a testosterone deficiency because their best friend's on testosterone, I check them and their testosterone level's fine. Okay, then you have to delve into exactly what's going on. You find relationship issues. It's not that they have ED, it's just that they don't have sex with their wives. And guy to guy, I have to talk to them about, hey, what are you going to do about that? You know, so therefore it gets really involved with the socialization process. Contrary to what most people think, maybe you think that way, I don't know, I never asked you, but men don't want to have sex with just anybody after they mature a little bit, maybe in their 20s.
Okay.
You disagree. But in my experience, especially those that are married, marital issues, relationship problems can get buried very quickly with men. And it sits there and it basically eats them away at their own sexuality.
It goes back to them not speaking up, not being as open. But I do think men tend to need the novelty a little more than women. We have more emotional connection and like the intimacy, where men are like visually stimulated and like novelty.
What do you say? What are you saying?
New things.
Men cannot be faithful to a woman. Is that what you're saying?
I didn't say that. I didn't say
I
that.
agree with you, absolutely. However, just because someone has a need does not mean they act on it. Okay, so action is different than having a need, but discussing that need or discussing that whole aspect of maleness is exactly what I'm talking about, is that women should be interested in what the male has to say, as opposed to saying, you know, you're looking at that girl and goes crazy because she's so jealous and shuts the male down. That's going to shut down his own sexuality toward her.
Right.
Because, you know, that's
it's
how
like
we're
a
built.
vicious circle.
And then they complain, you know. But I have had people, men, who have totally normal levels of testosterone. Psychologically, there's some issues, but not much. And I check their adrenal gland and it's shot. And it's amazing to me. I said, when did this start? And sure enough, it started shortly thereafter their vaccinations. And so I checked the adrenal gland function, gone. So in other words, when you really look at the time element of problems, when did it develop? When did it start? And everybody just blames testosterone. That's easy. Do you agree with that? You find a lot of other issues that may have happened medically, right? That especially today, are dealing with relatively young, healthy males. Now, I have seen...
deal with already hypertension, metabolic issues that affect their sexual function, too.
I've seen young women, after getting the COVID vaccination, who are infertile, but also are anovulatory. They don't produce an egg, which produces progesterone, which converts to testosterone, so they begin to develop other syndromes, but it's not addressed by other doctors that in itself can cause, for example, sexual issues. Speaking of young women, we have hundreds of young women who are on birth control pills with serious sexual dysfunction. What I mean is that they have no sexual desire. They cannot orgasm if they do have sexual intercourse, except for with masturbation. And they are emotionally depressed, they gain weight, and they lose their sex desire. Is that your experience as well?
Definitely.
Okay. So we have developed a program for these younger women, let's say from 16, 17 to 25, that give the hormones they need, and you can stay on the birth control pill. Nobody has
You need that
ever...
contraceptive effect.
Yes,
that age
if that's
group.
your decision between you and your gyno, I'm not going to interrupt that. I mean, I believe there's certain better ways, certain not so better ways, but that's not the point.
No, we always discuss options, and then they need to understand that it's just providing contraception. It's not balancing your hormones.
And what is the hormone in the pill? People
progestin,
progestin,
which is supposedly the progesterone,
not
but
progesterone,
it's not.
people. Your doctor is lying to you. He doesn't, or she doesn't even know it's not progesterone. It's synthetic progestins that are the opposite effect, which causes what?
Depression and
weight gain, low sex drive. There you go. So stay on that if you have to, but then give yourself the progesterone, the testosterone, the human estrogen if you need it. Remember, the pill does not contain human estrogens. These are synthetic. And nobody really knows. When I researched this, I tried to find articles that shows how and whether or not it's converted to the human estrogens, which is estradiol and estrone. And guess what? Nothing. It's not. So you're getting estrogen effect that has no real long-term study, except now we're beginning to see studies, retroactive, increased infertility, increased obesity, increased glucose intolerance, insulin-resistant diabetes, increased heart attack, increased hypertension, increased chronic depression, increased infertility. So in other words, now looking back, which is what I've said the whole time, no one should be on the pill after 35, for sure, because of the breast cancer risk, but definitely those that need to be on it, you need to get a program where you replace the hormones that you need to maintain your future fertility.
But at that age group, when they go in for those symptoms, they don't look that they're on the birth control pill, and they don't think, oh, it has nothing to do with your hormones because you're young. There's nothing wrong with you because you're young.
Well, the question is, what's the difference between a moron and an idiot? That's what I always say. I'm trying to figure it out, and the bottom line is that I hear this stuff all the time from doctors. What are you doing to the patients, and they're having symptoms that are secondary to the pill, and you're telling them, here, take an antidepressant.
Exactly.
That's what they do. How many times a day do we get that? Multiple times on young women. So the answer is, the real answer is, does this doctor know the first thing of what they speak? That's how cynical I've become. And I say absolutely not. If they don't have the time to research and understand the prescription they're giving, what the side effects are, and when the side effects present themselves, here, heck, another drug. To me, that's insane. Call me crazy.
Just a rabbit hole.
So you've been doing this now thousands and tens of thousands of times. So in your view, just not only as a woman, but also as a practitioner, what is the reason why people don't question these issues? Why aren't doctors saying, or for that matter, intelligent patients, why am I having these problems? Now, a young woman who's depressed, gaining weight, and no sex drive, that's a mess for them. Now, then it deals with all sorts of other issues. In fact, the study was done that cerebral if you take the pills between 16 and 21, it can cause retardation of your cerebral frontal lobe development, which is where relationship issues develop. And then they want to know why they have problems with relationships their whole life. It's a fascinating study that is absolutely guaranteed true. So I'm not saying I'm a big fan of birth control pills, but at least the deficiency of progesterone and testosterone and adrenal gland and proper human estrogens probably causes all of these issues, especially metabolic issues, as you know, from adrenal gland and progesterone.
I was just going to say that with metabolic issues, because that's usually when things start to change. They have eating habits through their teenage years, and all of a sudden they get to an age and everything is changing. Start to put on weight distribution changes, and no one addresses that either. Looking at the side effects of the medication or just nutritional assistance. It doesn't take 5 minutes to kind of go over a quick nutritional assessment and guide them in the right direction.
Well, it brings into light, the whole aspect of human sexuality, but also reproduction. Meaning, in most cultures, until very recently, in the Western civilizations, girls, and there are girls, would get pregnant at 16. They get married at 16, boom, they get pregnant and have a baby every year until they're 24, whatever it is. And they would be constantly producing progesterone. Meaning, not only when they ovulate to produce progesterone, but progesterone is the main hormone of pregnancy. So if they are pregnant most of their young lives, obviously there must be advantages to that if you look back at history, okay? Because progesterone is the is the hormone of mature women who ovulate and reproduce.
If you stay pregnant all the time, that placenta is just belting out all that progesterone the whole time.
So not that I know why, but there must be something good if that's the way it's built, because it surely worked for a million years. And my point is that's true with all mammals, by the way. So progesterone deficiency, for example, if you have a woman who is pregnant, and you know that because you worked in a delivery center, they will describe their sexuality. In fact, I did in one of my articles. I actually produced the information, the sexual life during pregnancy. That was my master's thesis.
It always increases.
It increases as it parallels progesterone,
And also in combination of you're already pregnant. There's not that
Maybe.
underlying worry of,
That's a
am I going to
female
get pregnant?
thought.
I'm already pregnant.
I don't think men think about that, really, to be honest with you.
I
But
think women
they
think
think
that
we're
way.
afraid. We're afraid we're going to hurt the baby somehow. They really they egoize it and say, "Look at me, I'm going to hurt the baby." That's what the male does. But the pregnancy relationship between sexuality during pregnancy and progesterone is parallel. And what happens at the end of pregnancy, before labor ensues, when progesterone drops? Women want no part of sexuality. Boom, done. Zero. What happens after the baby's born? No progesterone. Then obviously there's a reason why. Metabolically, there's a reason, and medically why. It's not good to have sex right after a baby, for example. And then when the woman breastfeeds, that also resists or lowers the chance of ovulation, but also cuts out their progesterone.
Definitely.
So that's when you get postpartum depression.
And then women say that when they get in their 40s and they start to lose progesterone. I said, I'll explain that to them. It's like you're going back through postpartum depression again. They go, that's it, exactly. That's exactly
how I feel. So in other words, why do we bring it up today? Is because if you look at the sexual history of women, it parallels progesterone. I'm not talking about birth control pill patients because they're taken off the scale. So in other words, when they say women peaks at whatever age it peaks, that's such nonsense. What they're peaking is their progesterone production. That parallels. So I have thousands of women in their 60s and 70s who have sex 2-3 times a week, like they did their whole life, because we give them the hormone that makes them feel a certain way and make sure it doesn't hurt. So therefore, I look at it differently. I look at the replacement of hormones to parallel what was meant to be. And therefore, women should not start having desire and sexual activity in their 60s and 70s. We have women in their 80s.
Oh, yeah.
It's no issue.
It's getting for men.
That's why I see
way too much information that I ever wanted to know.
Right, but then we get the male involved, and we fix them. It's a loving couple. They've been together forever, and it is amazing how easy I see it, how easy it can be to be fixed, and we're not doing it. We're telling women in their 60s and 70s, which is our parent generation, don't have sex. If you want sex, find it else. Go outside the house. Have sex with your secretary. So I don't think that's really very healthy, but that's what the women had because it hurt. They didn't feel like it. They didn't have any desire. Plus, they became morbidly obese, which is another issue of sexuality. The whole issue today in America, we have 60% obese rate in women, 60%, and another 20% are overweight. Well, that takes away the attraction to a lot of and they feel it. You don't make it up. It's not like we're accusing them of anything bad. Nobody's dealing with the metabolic disorder.
The obesity rate's tripled since the 1970s. But then that's also when the whole food pyramid and glass of milk
You want to go into that?
Picture,
you want to go into that about what that was about?
Well, it's just to say that grains were healthy. They pretty much said that taking cheap animal feed, they decided to make billions of dollars off of it by advertising it to humans to eat. But we're not meant to metabolize that. We're hunters and gatherers, so that's what you need to put in your body to keep your metabolism going.
That's right.
So all the grains and milk, we're not baby cows. A baby cow triples its body weight in 8 weeks' time off of nothing but milk. So then people are having dairy and cheese and milk and then wondering why, they have all this belly weight.
I love the story of oats. Now oat milk. But I have a few patients who are in Lubbock, Texas, and they're all ranchers there, and we talk about nutrition and diet, and they laugh because they feed the cows before they go to slaughter. They feed them oats to fatten them up. They said it's the most amazing thing. They'll gain 25 pounds in like 3 days.
But then you turn it into oatmeal and fortify it.
And all of a sudden,
look how heart healthy.
All of a sudden, it's a health food. So you have to realize that marketing companies take over the truth. And we had that in pharmaceutical companies. And we have that in sexual arenas as well. Okay, so women were told if they have a sexual dysfunction in their 40s, 30s and 40s, whatever reason why they thought they had one, they were given high dose male levels of the pellet.
Oh, the testosterone.
Testosterone. Oh. So they come to me, and they felt terrible. They were horny. They definitely wanted to have sex with anything that moves, but their whole life was falling apart.
Oh, yeah, because it burnt through their adrenal glands.
Exactly.
And their hair's falling out.
And you know what?
Sometimes they have like clitoral enlargement and their voice changes, and then you get things that don't reverse.
So what we do, we check their levels. These clinics don't check their levels because they know that it's going to be male levels. So I tell the patient this, and I'm telling you all, what you're doing with pellets is you're transitioning to male without consent. Period. Now, if you like it and that's something you want to do, that's fine. But that's what you're doing. So if you want to burn out your sexual life long term, burn out your adrenal gland, I've had probably 20, 30 patients who have baldness. They're bald. They are not going to get their hair back. It's a sensitivity to the high dose of testosterone. They don't resolve. Even they have to be on proper replacement. Their hair does not come back. So why? What happens?
Unfortunately.
And it's nothing to do with dihydrotestosterone. It's another myth.
Every
I've
single
checked
time we check that as normal. Every
hundreds of
single
patients.
time.
Oh, my family doctor says it's converting to dihydrotestosterone, and that's why you're losing hair. We checked hundreds, maybe 1,000, zero. By the way, just like hypothyroid, how many new hypothyroid patients have you discovered? They check thyroid every 3 months.
They blame everything on the thyroid.
Yeah, but they blame everything on it.
I mean,
I've yet to find
rarely.
one new thyroid patient. I've had over 1 million patient months of experience. Not one new thyroid patient. Everybody's on thyroid medicine if they have these, quote, symptoms. But the thyroid profile is normal. So is a condition, which does involve sexuality, is pseudo-hypothyroidism, which means it looks like hypothyroidism, but it's a deficiency of progesterone and testosterone. But it looks like it, so the doctors who don't know anything say, oh, here's a thyroid medicine. Let me see you every 3 months.
That's why on the pellet they automatically slap that thyroid medicine.
That's
on it.
right. They're trying to treat the
Because
symptom.
a lot of patients say, I'm on thyroid medicine, but I'm not sure why.
So we have a group of patients who get very hypersexed with testosterone. And if they're married and they're able to go ahead and function with their husband, it's not a real problem. They just mention, I want to have sex all the time. But with the pellet, it's not just they want to have sex all the time, they can't orgasm. So
And they're
there's
more frustrated.
it's a very interesting sort of thing, which I haven't worked out biochemically, is why are they testosterone levels off the roof, they can't orgasm, but they want to have sex all the time. What is that? I don't know, because I haven't read anything that really gave me a concrete answer. But it's a fascinating, kind of subset of patients. And so unfortunately, the damage is done, but we get them off the pellet, obviously. You know what? How long after a pellet is inserted do you see high levels of testosterone? By the way?
Months. I mean, we've
Not
had
3
two
months.
patients 9, 10 months
Correct.
down the road. I'm wondering about the testosterone, like with a hypersensitive arousal disorder, where they're aroused all the time. It's that their testosterone is usually high, but they don't have an orgasm. It's
Right.
usually painful.
Right.
It's swollen and
And
painful.
I don't know the
There's
answer to that, but I definitely see it. And that sometimes stays over for a while. So I don't understand what it really involves, but I do see it. And again, they don't tell you when you do pellets. Everything's great until it's not great. One of those things. So
That's when we get them.
that's
it was
when-
great for 2 years, and now I feel horrible.
they
feel like
crash.
they're falling apart. They always, I'm falling apart.
And we have to put them back together. Like Humpty Dumpty thing. So I think that's, nuances, but definitely very real. So in the male compartment, what I find is that a lot of men who do have sexual dysfunction is not the majority of men that come to us for testosterone. Most of it is energy and muscle loss.
Muscle loss, that's a big one.
So for men who feel like you have these symptoms and your doctor gets your lab work, okay, they get your lab work, whether they know what they're getting, they get lab work. And they always say to these guys, it's normal, because there's a range. The range is, X to Y. And they say, you're in the range, but I'm having these symptoms. Well, you need it. Here's an antidepressant.
That's a big thing with women, too. Oh, I went to my doctor, all my labs are normal. You're in the reference range, but yes, it's for a 65-year-old woman.
Correct.
So zeros are in the reference range, but you don't want the hormones of 65-year-old.
Well, before you were born, when I started this, I checked about 1,000 women to figure out what levels you want to have, and I picked the age range from 35 to 42. And my goal was to narrow down the dosaging so that it would be specific based on a lot of other factors, but also getting that range, because that is the natural peak of women's health hormonally. And that's why so many women feel so good. It's not just taking the hormone. It's also knowing how to take it. These pill that came out, progesterone estrogen pill, you take once a day. Half the time you have no hormones. Nobody checks it. Nobody knows. Here, take the pill. I'm not getting better. Doesn't have testosterone, doesn't do DHA, doesn't do nutritional issues. So therefore, again, basic, like I said, 4 floors, right? Foundation, nutrition, no matter where you start.
Still leaving out that testosterone.
Then sex hormones with testosterone, then adrenal gland, and then everything else. That's the 4th floor. That's the last thing to attack, including weight. People go right to the GLP-1s. The doctors, the idiot endocrinologist who I had to deal with yesterday, who was putting this person just on GLP-1. She was on it for 1 year and lost 20 pounds. Her adrenal gland was shot. Her hormones were totally deficient. She had like 6 nutritional deficiencies, and he kept on raising it up.
But the minute you stop, you're just going to rebound. If you
No,
don't
but
take care
only
of all of the picture,
20 pounds in 1 year. Do you know how much it costs the
how
system?
much money?
Oh my God. And keep on doing it, keep on selling it. So if you don't understand the fundamentals of what I just talked about, it's not going to work.
Right.
So we hold off on the weight loss because that's a symptom. That is not the cause of the problem. We try to deal with the cause of the problem, which I gave you the foundation. It took me years to figure out that paradigm. And without nutritional assistance from the beginning, your body does not have the nutrients to build what you want it to build. It's so basic and so fundamental in medicine that's ignored. Because in training today, there is no nutritional training.
At least we do a nutritional assessment.
We
and
on everyone
says
now.
No one has ever checked this.
And now we can do it laboratory-wise. It's objective. This is your value. This is what you need to be.
They're randomly taking supplements, and most of them will say, I'm taking all this stuff, I don't
I don't even know why I'm
should be
taking it. Right.
So then we break it down.
That's correct. And there are definitely doctors who are trained in nutrition, who are excellent, who know a lot, but they don't address the next level to effectuate the change, which is the sex hormones and adrenal gland. So without that, they're just stuck there. So it's a good base, and then we have to build it up to the point where we increase the longevity of the patient, but also in sexual health, the satisfaction and relationship building that occurs between a man and woman that is long-term, that is effectual. We're not going to talk about the young dating, type of woman who is going out there and doing her thing. We're just talking about stable relationship sexuality because you agree that's 2 separate issues?
Definitely.
Yeah.
Completely.
So, but in our hormone patient, for example, in our young adults, we have 4 divisions now. In our young adult division, these women are told they have, quote, polycystic ovaries. What are they going to do? We're going to give you on birth control pill. That's it. Done. Finished. Goodbye. Meanwhile, their symptoms still persist or get worse than antidepressants.
This is a disorder of, again, progesterone deficiency all their life.
How'd you get so smart? Okay, so I hope you all enjoyed it. It's been fun for us. And if you want to ask questions, we have, you can send us an email at info@hormonify.com. And Kristi will probably be the one who's responding. If you can mention Kristi with a K, and we'll see what we can do to help you. So have a nice day.